So let's talk about getting into the chest. We've decided where to cut. You've said that we're going to avoid the caudal aspect of the rib to avoid the vein artery nerve. Where do you cut? Do you try and cut in the middle between the two ribs, or stick to the cranial edge, or what do you aim for when you make your incision?
The middle is what I'm doing. Now, it depends also on the size of the pets. You know, a smaller pet, you have less say in where you're going to make your incision between the ribs. A larger pet, you can maybe get a bit more precise and aim towards the more cranial aspect of the rib. But in general, I'm not even considering the vessels and nerves. I'm going right in the middle of the rib space. I was going to also mention regarding the musculature too. You know, we do know that if you're able to spare muscle groups rather, like latissimus dorsi, for example, serratus ventralis, and if you can keep those muscles intact, that'll help with postoperative analgesia maintenance too. So you keep that in mind too. But of course, you could always cut muscle if you need to, because you don't want to limit the reason why you're there surgically, just because you're trying to save a muscle belly. But if you're able to approach where you can retract muscle groups instead of cut through them, that's preferred as well. But likewise, if you do have to incise through muscle bellies, then of course make sure that you are able to reoppose those muscle bellies as well. You want to connect the appropriate muscles together, right? So sometimes we'll have, before you get too deep into thoracotomy, you can place a suture or two into the muscle bellies to retract them. So you've incised the muscle belly, you place a suture or two as stay sutures to retract them, and then you know what muscle bellies are going to be reopposed when you're ready to close the incision afterwards.
So what are we looking at? Latissimus dorsi, what else?
The serratus muscles in general, whether it's ventralis or dorsalis, those are the major muscle groups. But I'll tell you, this is what I meant by avoiding kind of the academic side of this. At this point in my career, I'm just wherever the muscle is, I'm trying to either save it or transect it. If I do transect it, make sure I know which end goes to which end.
Okay. And then getting through the ribs, it's getting very granular and probably personal choice, but are you cutting with scalpel, or do you prefer electrosurgery if you have it? Because I'm just imagining cutting those muscles between the ribs. Does it bleed quite a bit?
Yeah. So for skin incisions in general, going back to the skin, I prefer a blade. I've had both my own patients and, human patients, right, friends and family who've had skin incisions by cautery. It never looks as good when they heal, to me. The blade is better for cosmetics. Now, dogs and cats, they really care. They don't really care, but it's nice to do that a little extra. So for the skin, I'm doing a blade. Then for the muscle bellies, if I'm going to transect them, then cautery is ideal for those. There is going to be a lot of muscle twitching. If you've ever performed an amputation, you know how much twitching there can be with large, especially if you're dealing with like a golden retriever or something, a breed that commonly gets pericardial effusion. So those muscle bellies are going to twitch a lot. So it may throw you off course as you're trying to cauterize to transect, but keep that in mind too. But anyway, so cautery for the muscle bellies, and then to get into the actual chest, typically with that, it's going to be a pretty controlled, safe, just puncturing with Mayo scissors is fine. And then from there, you can, just like linea alba, you can just slowly cut with scissors, with a Mayo scissors or Metzen bombs, depending on the size of the pet, how gentle you are with your instruments, and then opening up the pleura that way, both cranially or dorsally and ventrally.
Yeah, that was going to be my question. How do you get into the chest without worrying about actually accidentally puncturing a lung or something? Is it easy enough to identify the pleura when you get there? So are you cutting little by little through the chest wall, through the musculature, until you go, okay, now I can see pleura? Is it easy enough to identify and avoid accidentally going, oops, shit, I've got a hole in the lung?
Yeah, depending on the size of the patient, if you're working on a very small breed dog or a cat, you may enter the pleura very easily. However, in most cases, it's going to act like a linea. It looks like a kind of a shimmering tissue. It's kind of shiny, and it is fairly thin, although in some cases of chronic pleural disease, it can be quite thick. But in general, it's kind of a thin, shimmering layer. And what you're going to do is an initial poke, again, with control. You're not looking to dive in accidentally, just an initial poke so you can get through, make a defect in it. And then from there, just slowly with Metzen bomb scissors, let's say, cutting the pleura. And then eventually, it doesn't take much for you to be able to visualize moving lung tissue. So now you can see the lungs. And because these patients are on mechanical ventilation, the lungs, every time there's inhalation, the lungs are going to expand. You can stop cutting. Once they're exhaling, you can continue your cut. And so that way you don't inadvertently cut the pulmonary tissue, you can cut as the patient is breathing. So every time they expire, the lungs deflate, and you can proceed with your cutting. When they inflate, stop cutting. And that's going to become more evident to you as you go through the procedure, because when those lungs inflate, they're going to be popping through your incision. So it's going to be hard to mistake in them otherwise. So that's why you kind of wait for the exhale to occur, and then you can proceed.
So that's my next question. So now you've opened, you're in there, and you want to go do whatever it is you want to do, but you have these lungs sliding in and out and moving around in your surgical field. What do you do with them? Let's say I want to access the esophagus, or it's not the lung, or there's a specific lung lobe. I want that lung lobe to go chop it out, but it's moving up and down. How do you manage that?
Yeah, it's a problem, because it's the same way you can't stop the heart from beating, right? So you have to keep going. However, the real answer is either A, you're trying to find ways to gently retract the lungs, which you can. You can use laparotomy sponges, wet them mildly, wrap the lungs that are in your way with the sponges, and then you can have, this is where an assistant comes in, because the retraction, the self-retaining retractors aren't going to help with lung, they're just going to help with the rib spaces. So now your assistant can gently hold the lung tissue back, or one lung ventilation. If you have an anesthesiologist there and you can just ventilate the other lung lobes instead and not ventilate the ones that are in your way or the ones that you're trying to operate on, then one lung ventilation is the way to go. I will tell you right off the bat, not being an anesthesiologist, it's either I'm spoiled they're there or they're not there. If they're not there, I'm dealing with bilateral lung inflation, and oh well, I'm gonna deal with it. But if I have an anesthesiologist there, then one lung ventilation is the way to go.
But the reality is, if you don't have that, you are just going to have to dance with the lungs to get to where you want to go.
Safe, gentle retraction with laparotomy sponges and an assistant to hold things out of the way. Otherwise, between everything you're doing, every time the lungs are in your way, you wait. When they exhale, when they deflate, you go. And you just keep working with that.
And is the same hold true for if you are actually working on the lung? Let's say I've got a lung bulla that's popped, or tooth has gone through a lung and I need to go and cut a section of lung lobe out. You just work with it in the moments when it's stationary, in between breaths. You just go, okay, work a little bit, hold back.
Same thing, but a lot of times if the lung is diseased sufficiently enough, it's not inflating much for you. If you're dealing with like a pulmonary mass, which is the most common reason why I performed thoracotomies was for cancer. Single pulmonary mass, no evidence of metastatic disease based on our staging. I'm removing this one mass, or one lung lobe rather, with the mass involved. It's not inflating that much. And so the affected lung lobe typically isn't bothering you anyway, or it's a lung lobe torsion. There's no air going through that lung, so it's not really inflating. Now, if you have a bulla or something like that, then yeah, the rest of the lung is going to be pretty healthy, and it's going to inflate as you work. But in most cases, if it's really bad disease, or there's enough lung compromise, it's not going to inflate anyway, the one that you're targeting. The surrounding lungs though, will get in your way, because they're just going to take up the space that the collapsed lung is. So you still have to deal with it to some degree.
Okay, that helps. I feel like it's one of those things where you have to maybe watch a few, if you can, to get your head around these sort of things, because I've never done it. I'm trying to imagine what it'll be like, but watch it before you do it if you can help.
I've looked at plenty of YouTube videos, even as a specialist, to see how other people perform procedures, or if it's a procedure I've never done before and not a lot of people have in that area or whatever it is. YouTube is fantastic for this stuff. So if all you need is a little bit of guidance, coupled with all the reading you've done and with the surgeons you've talked to, etc., it's a really great way to kind of see in real time what's going on. People do film a lot of this stuff, or other platforms too.
I'll see if I can find some cool videos and link to them in the show notes. It's a great idea. Shadi, I wonder, maybe rather than diving too much into individual procedures, we can always circle back and do an episode on the esophageal surgery or a lung lobectomy or something like that. But let's leave it as the broad principle. So we've done the thing that we want to do. I'm just trying to think, maybe let's talk about getting out again in a safe way. So whatever we've performed, we've finished. Just maybe one question for a penetrating wound, a traumatic wound, or a bite wound or something like that. You can flush the thorax like you do an abdomen, right? So heaps of warm fluid in there and then just suck it out again. There's nothing different or unique about that, because I'm assuming you're exploring the bite wound, and I'm asking for selfish reasons because I feel like that'll be the most likely scenario that I'll be going into a chest. Go and debride any dead tissue, check that the lungs are intact, and then just flush it out.
Yes, before you start flushing, you could go either way with this aspect to it regarding culturing the area. So you may feel compelled to culture the affected tissue, right? And now, do you culture before you clean everything up? Do you culture after you lavage? Which do you do? And so if money's not an issue, you could theoretically do both. But in my own personal preference is I tend to culture right before I'm about to close. I clean everything out, problem solved, patient is okay, right? Because I want to know what's left behind. But I know plenty of doctors that'll say, no, you want to stick that right in the pus and get it. And so I don't know the answer to that, but I just want to remind you, culture something, whether you're doing it before or after the insult, culture something if you have the finances in that case to do it. So just keep that in mind. But yeah, the main difference though with lavaging the thorax and the abdomen is you have control over the ventilation if this patient is on a ventilator. And so if you're really trying to look for any air leakage, you want to be able to have the patient inhale, so positive end expiratory pressure, increase the air in the lungs and maximum inflation, and then hold it. And you're looking for bubbles. Otherwise, if the patient is breathing sort of automatically, you might miss something. You want to be very detail-oriented about that part. Whereas the abdomen, you're kind of just lavaging for the sake of lavaging and getting rid of all those bacteria and leukocytes and everything else. This, you're also looking for air leakage. And so you want to hold that inspiration, look for the bubbles, and then you can lavage.
So to be clear, you're putting fluid in there, basically submerging the lung that you're concerned about, and then checking. So it's like when you're fixing a bicycle puncture, put the inner tube in a bowl of water and checking for the bubbles.
Yes, exactly. And so it also matters what suction device you use too, right? Most of us are going to use a suction pool. It's going to be multi-fenestrated metal tip. You don't necessarily want to use like an orthopedic suction tip for this. So the lungs, to some degree, they act almost like omentum, the healthy lungs, very soft. You want to be careful when you're suctioning, you don't just blindly go in there, in the rough house. You want to be able to gently retract the lungs away, go into all the gutters, visualize where you're pointing that suction tip. It's not as forgiving, if you hit lung tissue. You don't want to create a pneumothorax post-op because you're too rough in lavaging intra-op, right?
Yeah. Because I did wonder about that, because you've got limited space, and then, as you say, the lung keeps impinging on where you want to work. So the ones with the multiple holes down the side, you're not going to get lung tissue get sucked into that as you would with a big open hole.
You will if you don't retract the lung lobe. You have to retract them and then you use that. The reason why I want you to use multi-fenestrated is because just like the abdomen, it's got gutters and crevices where fluid is. And so an orthopedic tip only has one hole, and you're not going to be able to see everything. You're going to leave fluid behind, of course. That's one reason why you place a thoracotomy tube for these patients. But you want to multi-fenestrate, just make sure that the lung tissue is kept away so that they don't get traumatized by it. Be very gentle. And don't forget, of course, contacting the heart too. If you contact the heart manually, you're going to see heart arrhythmias. You're not going to cause a devastating problem, but just keep that in mind. The heart will be there, and so you want to try and minimize contact with the heart as much as you can as well.
I can't believe we haven't mentioned the heart until now. The other big thing that's
I know.
gonna be there, man.
There's so much to this. There's so much detail to this, So
yeah. As I said, that I'm aware that you're going to have to do a bit more work than this podcast, but at least getting some ideas in my head. I think questions that I've always had about this. It's so nice to talk to somebody who has done this. And so I'm done. I've suction. I've lavaged. I've suctioned. It's clean. Now I want to back out of there. I've got a big open hole. At which point do you place your chest drain?
So in general, you're going to be aiming proximal 1/3 of the 10th to 11th intercostal space. And then that's your target area. But then the thoracotomy tube, the chest tube, is going to be then, you're going to create a tunnel from that 10th or 11th intercostal space cranially before you pop into the pleural cavity. So there's going to be tunneling of that tube. So that puncturing into the pleural cavity is probably going to be somewhere around the 7th to 8th intercostal space. And then another thing to consider, because air rises and fluid doesn't, what is your goal with the chest tube? Are you planning on there being air as the majority of the issue you need to deal with post-op, or is it going to be continued fluid production post-op? And maybe it's always going to be both, but what disease are you dealing with, right? So if this is a pneumothorax case, you want to know if there's going to be more air afterwards. If this is a carcinoma of the lung and there's pleural effusion, well, you maybe be focusing more on the fluid. And so the chest tube either should be a bit more proximal if you're looking at air, or a little more ventral if you're aiming for fluid production post-op. But that's my own sort of experience with it. maybe it doesn't matter, but maybe it does. So you're going to penetrate the skin at the 10th to 11th intercostal space. You're then going to tunnel forward using a Carmel forceps or some sort of long forceps with the chest tube before you enter the pleura at the 7th to 8th intercostal space, puncture into the pleura, and then it's in the chest. Now, the reason why you want to do this before you close your incision is because you can visualize that puncture. Most of the time when we're placing a chest tube, we're doing it blindly. So you're going to puncture and you don't know what was underneath. You have the benefit of in surgery to see where you're actually penetrating that pleura. And so you can actually look and feel and protect all the organs from there, all the viscera rather. So then you place the red rubber. Key thing to remember, red rubber tubes, let's say, that's what I use most often. I'm sure there are fancier thoracotomy tubes out there. They only have usually, I think, 1 or 2 holes at the tip, depending on whatever. You want to create multiple holes. You want it to be fenestrated because it can also get blocked with debris and lung and whatever. So you're going to cut the holes by bending the red rubber, cutting a segment out, and your alternate sides that you cut the hole. The holes can't be too big or else you've got a very fragile hinge point. You don't want that chest tube to break in the thorax. You also don't want the holes to go so far up the red rubber that it's exiting the thoracic cavity. That defeats the purpose. So you have to plan your cuts when you make these multiple stomas in the red rubber. So just keep that in mind too. There's an art to that as well. And then you place the tube.
Okay. So just to be clear, so before you go into surgery, you're going to surgically prep, keeping in mind that you want to put a chest tube in further caudal to where you're cutting, and then insert. So do you drape with that still within your field, or do you shift the drape? Or
yeah, you're shaving the chest. Basically, the margins that you're shaving for the technicians or whoever's shaving for you, it's going to be dorsal midline, so thoracic dorsal midline, just caudal usually to the costal arch, as cranial as you want to go, but thoracic limb, like shoulder area, like right before you hit the shoulder, and then ventral thorax, sternum, right? Assuming this is a thoracotomy. Obviously, it's going to be different if you're doing a sternotomy. But you want a very wide shave job, especially for what you're doing, Doc. If you're going to be exploring for a wound, you don't know where you're going to go with this. Are you putting drains in? Are you not? You don't even know, right? So you want to shave very wide. And then the other reason for shaving wide is for the chest tube, exactly. Because if you're going to enter the 10th to 11th intercostal space, well, you're already towards the costal arch now. You don't want hair to start poking through your drapes. So shave wide.
Gotcha. So chest tube in, and as you say, it is very nice for once that you can actually visualize the little tube coming through and then go and put it where you want it. Because usually you're doing it blindly and you do x-ray and you go, oh, shit, that's completely in the wrong area. I wanted it way down here, now it's up there. And then we start closing. So talk us through closing. Do you close multi-layer? Do you have to close the pleura specifically?
You're going to secure the chest tube at that point, right? You're happy with where it's at. You make sure you've got multiple fenestrated holes that you created. None of the holes are sticking out of the skin. And now you want to use usually a finger trap pattern, or you can do a purse string, but I do a finger trap. And there's plenty of pictures online with that. That's easy. But so anyways, you want to suture a chest tube in. I'm typically you can use any suture you want. I'm usually using like nylon, 2.0 nylon, but you can do is Proline if you want to. Doesn't matter. Just make sure that's going to hold. Once the chest tube is in place, you secured it with a purse string or a finger trap. Then you're going to close the remainder. Now, with regards to closing the ribs, opposing the ribs, you want a strong suture material to do that. So I'm either going to use Proline, like if it's a big dog, it's going to be 0 Proline, or if it's a smaller dog, maybe 2.0 Proline. Or what works really well is the same material you use for ACL tears. You're going to perform the lateral imbrication technique, the cruciate wire. That works really, really well for these. It's really good. And so you can use that instead to place around the ribs so you can oppose them securely. Strong material, very strong. Now, regardless of what you do, you're going to want to you're going to close the rib space with using interrupted, and you're going to pre-place them. Meaning you're going to encircle one rib, go into your thoracotomy incision, encircle the other rib, come out, and now you've got your loop, right? But before tying them, you're not going to tie them. You're going to put hemostats at the end of each end, and you're going to do that for every single closure. That entire thoracotomy, you've got a whole bunch of pre-placed sutures lining the entire incision around the rib space. Now it's a matter of tension. So you're opposing ribs back together, and they are not malleable. So you can, depending on the case and the malleability of that patient's tissue, you can either start to close the rib spaces central, moving proximal and distal, or starting proximal or distal and moving centrally. I've gone both ways. I tend to like starting proximal or distal, closing those and then moving towards the center, because what happens is the tension changes as you move up and down that incision, and it could loosen prior sutures that you placed. So you may have to, depending on how things are going and how tight your closure is, you may have to redo this so you can figure out what tension. The other thing that helps too, let's say you're at the center part of an 85, 100-pound dog. You're at the center part where the most tension is going to be, right? That's where the curvature of the thorax is most prominent. You're trying to get them together, you can't. What's helpful is the pre-placed sutures that are proximal and distal to the suture you're trying to complete, so you're trying to close. You have the assistant pull on one pre-placed suture in a caudal way and one in a cranial manner. So by pulling opposing tensions, you can then close the center part. So there's tricks like this that you can use because there may be a fair amount of tension when you're trying to close these.
So just to be clear, so let's say you're starting dorsal or ventral and then working your way up. You have those pre-placed ones. So you're knotting those. As you do them, you're placing your knots, moving centrally. When you said you've got to you may have to redo it, would you then have to go and replace, as in put a new suture through more cranially or caudally where you were? So you're not temporarily securing them and then going back to readjust before you knot?
Correct. You can either try to untie your knot, which for a cruciate wire, you might be able to because it's so thick. But for a proline, you probably can't undo your knot. You're going to have to remove the whole thing and start again. And then you may ask, well, now part of my incision is closed. So now aren't I placing suture blindly? And yeah, you are. Now you are. The trick I was going to mention was related to that exact question. If you're going to pre-place or place suture blindly, you can try and use the blunt end of your needle instead of using the sharp end. That way, if you do hit lung tissue, you have less of a risk of penetrating it because you're using the blunt end of your needle. Now, it's a bit more of a force, but well worth it. Adjusted just right, you can get through with the blind parts and then exit. So
I'm assuming we're using a swaged on. So the blunt end of the needle where the suture material is attached to, that'll go through the chest wall with enough force. So you basically ass first going through there.
That's right. But here's the thing, though, that's a good point, because if you're using cruciate material, let's say, those typically you're tying those material on your suture knot, on your needle. So you have a pretty thick knot now. So in that case, it may not be as realistic to blindly go with the blunt end because you had a big bulky knot. But yeah, if it's a swagged on needle, then yeah, you can use the blunt end of the needle.
Okay, great. Just backtracking quickly, do we close the pleura individually, or is it attached to the chest wall? Closing the chest wall will automatically close the pleura?
Nope. Just start right with the ribs, and then after you've closed the ribs, you're happy with their closure. You're going to then reoppose the muscle bellies that you maybe transected prior, end to end, and you can do those, whatever pattern you want. You can do it continuous, is what I'm doing, or if they're really fragile or it's a small patient, you can do in a small, simple interrupted, whatever you want to do. And then from there, depending how fat the patient is, the subcutaneous tissue, then skin like usual. I'm always going to place either skin staples or skin sutures externally. I think it improves the cosmetics. It's such a big incision, and there's gonna be so much bruising potentially post-op with that I like having that extra reinforcement of either skin staples or my preference is skin sutures. I just do a whole bunch of cruciates down the incision for the skin. So during this whole process, because this is happening, multiple things are happening at the same time. Your patient's still on mechanical ventilation. You're trying to plan your closure, and then you have an assistant that once the first layer is closed, now you've developed a pneumothorax because air is still in there. So your assistant is now using the thoracotomy tube, the chest tube, to empty out air and fluid as you're closing the incision, right? So that has to happen. It doesn't have to happen simultaneously. You can alternate as a surgeon. You can close a little bit, empty the tube, close a little bit, empty the tube. But if you're trying to maximize efficiency and you have an assistant there who can use the tube, they're emptying out air and fluid as you're closing the incisions. You're going to create a tension pneumothorax while you're doing this.
Okay, cool. So we closed, it's done. We've drained everything we think. Do you do anything special? Like, do you do local blocks or anything specific for these guys? Because I'm imagining it's pretty painful.
There are a few studies that look at nerve blocks before you create your thoracotomy incision, or even before you, let's say, transect the latissimus dorsi or serratus ventralis, that you inject them with lidocaine for sure. Usually what I've done, I'm maybe a little bit more old school, I guess, maybe now compared to the literature that's out there, but I use lidocaine blocks on my way out. I might use them on the way in, but a lot of doctors now are using them for even for abdominal surgeries like spays. They're injecting before they even make their incision. They're injecting the muscle. So sure, why not? The studies look pretty good on it. It's not like crazy improvement, but it seems like it helps. It could help. But anyway, yeah, I'm injecting the muscle groups as I'm leaving with lidocaine. Yeah, what you want to, I think we're still in the camp of avoiding that in cats. The toxic dose for cats is still, it doesn't seem worth it for a local block, but for dogs, it seems like, although there is also a toxic range for them as well, for dogs, usually is what I'm doing this for, not for cats.
All right, we won't go too much into the critical care afterwards, but you said at the beginning, one of the ideal prerequisites for this is that you want good monitoring afterwards. Obviously, you've got a chest drain in there, you don't want the dog chewing it out or something.
Yeah, definitely. You need to have enough staff to be able to empty the chest tube and monitor the trends with the chest tube, be able to troubleshoot if it's not really emptying. Is it not emptying because there's no more fluid or air, or is it obstructed, or is there some mechanical error? I mean, and then you've got the patient analgesia management, pain management. Are they going to be on a CRI? Are they on opioids as needed? Where are you at with that? You also have to consider how stable were they pre-op if you're dealing with a septic patient, or one that came in like unstable for severe trauma, what have you. You need to make sure that you're monitoring ECG, blood pressure, PCV total solids, all that temperature, all that good stuff. And then from there, it's when do you feel comfortable removing the chest tube so that they can go home, assuming they're going to survive this operation and all that good stuff, go home. So all these things have to be taken into account. And then you're going to have cases where it's like, is this air too much, too little? Is this fluid too much, too little? Is there a problem? Should we re-image? Are we okay? All these things have to be taken into consideration when you're monitoring them post-operatively.
Yeah, we'll leave that for an episode on the ECC podcast. You're the surgeon. Your job's done. You can go to bed. You're not your problem anymore, am I right?
One thing I want to mention with closing the incision, though, make sure you focus on dead space. You don't want to have a seroma form. That's really annoying. The client just spent thousands of dollars for a high-risk procedure, and now you've got a seroma there a week later. That's annoying. So it's okay to close in multiple layers. Just make sure you're closing multiple layers. It's fine. You can't really overdo it. You don't want to get a seroma there for a procedure that was so cool and life-saving, and now you have a stupid incision problem that was avoidable. So,
and that's all that the client will notice, right?
That's all they're going to notice. They're like, what is this? Now there's a seroma there. Is that infection? Did you mess up? Is that lung tissue coming? I don't even know what that is. And they're freaking out and you're annoyed. It's a whole thing. You don't want to go in there and place a drain or something or reoperate the incision. That's just unnecessary. It's avoidable. So anyway, so I would mention that.
Do you bandage them at all? I feel like because there's air and stuff, the temptation is to want to cover them up, but then again, you're going to interfere with breathing.
I'm not a fan of them when the tube is in, and the reason why is A, I'm going to have an e-collar on these pets so they can't chew it out. B, if they do happen to remove the e-collar, the chest tube, I'm also going to secure it probably in two places to the skin beyond the finger trap. So that's going to be secured. But also, I want my techs to be able to look at the breathing pattern. A bandage is very difficult to monitor breathing patterns, and breathing pattern might be the biggest thing to look for post-op, because it tells you about oxygenation levels, it tells you about pain levels, it tells you about the chest tube working. So I need them to see the excursions and inspiration, expiration. So I really am going to try to avoid a bandage. After the chest tube is removed, things look good, dog looks great. Then I'll put a bandage on to protect the incision and the stoma, send them home, and maybe I'll have the owner come back in 5 days to remove the bandage and, look at the incision, make sure things look good, and then probably permanently remove it from there. We'll see. This depends. But yeah, I want to watch the breathing patterns. That's number one.
Cold. I think I'm done, unless I'm missing anything. That helped a lot. It's just a lot of those things, talking through it. Personally, I think it helps a lot to get my head around it. Are we missing anything obvious, or are you happy that we've covered it?
I guess one part you could consider is, the use of prophylactic antibiotics. This surgery is such a major surgery, whether it's a clean surgery or whether you're dealing with a penetrating wound and it's gross, esophageal foreign body, and there's esophageal leakage, whatever, I think you're kind of obligated to have prophylactic antibiotics on board. Usually cefazolin, or you could consider like an ampicillin type drug. But this is one of those surgeries where even if it's clean from the get-go, if you have an infection, it's a problem. And so a major problem, it's like a total hip replacement. Sure, it's sterile, but if you have a problem with that, with infection, you got a big issue. So I'm a fan of it. I know that's always the hot topic, antibiotic usage. I think you do. I think you use it.
Yeah. I'm trying to be much better at not using antibiotics when I don't need to, but I do feel like if I've been inside your chest, I'm going to give you some antibiotics.
You ought to have some coverage.
Yeah. And that was awesome. I really appreciate your generous time with that, and I can't wait to get this out there. That's gold. I'd love to chat to you again another time.
Thank you. Anything you need from me now or the future, man, I'm all yours.